beautiful people. You are live on a brand new season of Ladies Digest, where issues in the world of women are discussed. I say season because we are done with season 1, and the good news is that this season is going to be dedicated to women's health, so issues concerning women. And in season 1, previous episodes, we started with women's health. We treated GYN visit, and why you should have a routine check. We also talked about fibroid, we talked about HPV and how to manage it. We treated ectopic pregnancy and so on. And later on, we diverted to other issues, but now we are coming back to treat women's health. And in this journey we'll be embarking on, it will surprise you to learn of conditions you never knew existed, and some you might even be experiencing. So sit back and enjoy as we take this jolly ride. I'm Johnny Kuya, you are the stay safe. Dr. Kwejo Owusu-Ansah has been a practicing doctor for 17 years, 14 of them as a gynecologist and obstetrician. He is also a fellow of the West African College of Surgeons. He has since successfully helped several women achieve their dreams of becoming mothers through various assisted conception techniques, the oldest of them being a 59-year-old. His hobbies are weight and aerobic training. Welcome to our show, Dr. Kwejo.
Thank you very much. Happy to be here.
Same here. I would say we are very privileged to have you. Per your profile, I would say that we are really, really privileged, and I know our viewers will learn a lot from you. Yes. Thanks for honoring our invitation.
Sure, you're welcome.
Yeah, so today we'll be treating polycystic ovary syndrome, also known as PCOS. Yes. And in the course of the show, I would, in order not to bite my tongue, I'll go for the PCOS most of the time. Mm-hmm. Yeah, so I will just read a brief introduction, and it says that polycystic ovary syndrome is a health problem that affects 1 in 10 women of childbearing age. Women with PCOS have a hormonal imbalance and metabolism problems that may affect their overall health and appearance. So with this definition, I would want you to just help us with a very lay definition of PCOS that even a young lady, a 15-year-old lady would understand when you help us with it.
All right, thank you very much. So polycystic ovarian syndrome, which is called PCOS. Yeah. Actually, it's a reproductive or hormonal endocrinological problem, which happens or affects most women between 15 and 44, 45 years. Okay. That's the reproductive age group. Yeah. So what happens is that clinically, if that happens, they tend to have a couple of symptoms, which ranges from having menstrual irregularity. The irregularity could mean having menses every 2 to 3 weeks, to having prolonged absence, maybe 3, 4, 5 months, no cycles. Okay. We also could have problems with infertility and or struggling to conceive. So these are the two, the irregularity and the infertility are the two most common reasons why they tend up showing up at the hospital. Okay. There are other ones such as weight gain as obesity, and then increased hair, particularly facial hair, with regard to as a result of increased male hormone, testosterone in their blood, which is also part of the disorder. Wow, okay. Yeah. So we have just been able to establish that it occurs within women within the age of 15 to 40.
The reproductive age. The reproductive age, the childbearing age. So what are the causes of this condition? Will it be lifestyle or any other thing? Because per the young lady who is a 15-year-old lady, I won't say she's got a lifestyle already, maybe sleeping around or the kind of food. She will still be under her parents and will be eating some foods and all that are okay. So what would be the main cause of this condition? Well, so this day we don't 100% understand what causes polycystic ovarian syndrome. But what we found out so far is it's a combination of factors. Genetic factors seems to be the strongest predominant cause. So you tend to find one other female, mother and sister, female cousin with a similar pattern. Okay. So the strongest one is genetics, and then environmental factors, diet, weight gain, all that also contribute to it. Okay. So usually would show up
right after puberty, once your maturation is complete, or could show up in your second to third day. Women who are not in that category.
Okay.
Yeah.
So does it have any link with endometriosis in any way?
No.
Okay.
There's no direct link.
There is no direct link.
The same group of women are affected though, but there's no direct link between it.
Okay. So if I
facial hair, beard, everything, or increased acne, usually in the face, upper chest, upper back, or getting increased body mass, as in getting obese or getting overweight. Yeah. So those are the main ones.
I'm very concerned about the facial hair, the increased facial hair. So has there been any form of research to like link why is it the hormones? Why the facial hair?
Yes, so they tend to have, the ovaries tend to produce slightly increased or more than usual levels of the male hormone, the testosterone, in them. And then once testosterone levels are higher than the average woman, you tend to have all cells that have, or all hair, all areas that have hair that are responsive to these, particularly the facial one. Men have high testosterone, so we have hair, facial hair. Yeah. But then once you have high, beyond a certain limit, I like to have these hair in these areas respond as well. So yes, it's from a result of the heavy or the increased testosterone levels.
I see, with the beards and even on the chest and all that. And I see that would be quite embarrassing.
Yes, it has a lot of psychological effects on the patients as well. So yes, ultimately, if it's severe and prolonged, some can get into anxiety and some depression over time. Because of that.
Okay, so I guess because of the male hormones they produce, that will still be a contributing factor to the infertility, being that they are kind of, less, in quote, less of a woman or something like that, and they are, I don't know, maybe I'm not getting it right.
Well, what happens is that the primary cause for their infertility is that they do not ovulate on a regular basis.
Okay.
So typically, in the women who are not affected, every month at least an egg is selected. Sure. That process is not very consistent in them.
Okay.
So there are months that they ovulate, there are months that they don't ovulate. If they don't ovulate, they are going to go off their cycle for a couple of months. Along the way, they will ovulate and they will flow.
I see.
So that is the primary responsible factor for they not achieving pregnancy.
Yeah, pregnancy.
The androgen levels, yes, is also contribute.
Okay. I really get it now because of the irregular ovulation. So, okay, so we'll take a break here and we'll be back to continue. Hello viewers, this has been Ladies Digest and we've been discussing polycystic ovarian syndrome, also known as PCOS. And I've been here with Dr. Kwejo Owusu-Ansah. We'll go for a quick break and get back. Welcome back to Ladies Digest. In case you've just joined us, you can always catch us up on our social media handles on Ladies Digest, on our Instagram handle, and our Facebook and YouTube pages, Association of African Universities, to know what we've talked about, you can always catch us up there. Welcome back, Doc.
Thank you.
Yeah, so we've talked about the symptoms, we've talked about the general condition. So I want to talk about diagnosis now. What's, when I come to you, what are some of the questions? I know you've talked about the irregular menstruation and all that. What are some of the deeper questions you would ask for you to be able to know that, okay, this is the angle with which I need to diagnose here, and this is what I'm suspecting?
Okay. So unfortunately, there's no single test to diagnose PCOS. So if you walk to your clinician with a problem, the first thing will be to have a history, taking your story, listening to you, and then you would have presented one of the symptoms, either the increased body hair, the wanting to conceive or struggling to conceive, the weight gain, or the menstrual irregularity as well. So once you present with that, further questions will be knowing how long it's persisted. They will go back to your menstrual history, when it started, what the pattern was like, if it was normal before, any medications you have been on before, any previous interventions or diagnosed by anybody. Yes, those are the keys. And the family history. Is there anybody else in the history in the family who has such a similar condition? Yeah, I said there's a genetic component, so usually yes. So once that is done, they'll do an examination. So the examination would require just a general examination, looking at your build in terms of body mass index, looking at whether you have facial hair or all that, and then they'll examine your abdominal examination to see if there's a mass or anything. Usually they tend to form cysts as well, which is a fluid flow collections around the ovaries or in the ovaries. So they'll examine your abdomen for any mass, any pain. Then they'll do the ultrasound scan to see the nature of the ovaries, because usually ovaries that behave this will have a peculiar look on scan. So they will look at that, and then after that, your doctor may request for a hormonal screen to see how the reproductive hormones, the levels are, or if anything. Those are the, in summary, what's what they'll do for you when you turn up at the clinic.
So I guess here you spoke about they asking the lady her flow pattern, you know. So I guess this goes to show, this just tries to emphasize that we as ladies, we should know our bodies. We should get to know our bodies. It would be a good idea to know your baseline. So if anything should change, you could easily tell that there's something going on. Because I guess some people may just, it's normal, and if you really don't know your body, you will just feel it's normal and wouldn't feel bothered or worried to go to the gynae. Also, how, I don't know if to say dangerous, but how serious is this PCOS? How dangerous is it or serious? What are some of the risk factors?
We wouldn't call it dangerous. It's dangerous. But risk factors, yes, the weight gain is one. There's a genetic risk which you can't do very much about. You could modify the environmental ones, the weight gain and the diet and all that, but we wouldn't say it's dangerous. Usually, it's the psychological trauma of knowing that sometimes they feel frustrated with the cycle. And for those who are in maybe unions or married, the challenge is trying to get pregnant. So that also adds on to the frustration. So initially, these are the main two things: irregular cycles and then struggling to conceive. Going forward, as you get older, there's increased risk of getting the diabetes, as type 2 diabetes, when you grow maybe 40 years and beyond, if not controlled. Increased risk of endometrial cancer. And then the psychological component of it, and maybe weight gain, obesity with this associated risk of maybe sleep apnea, increased heart disease, and all that. So those are associated complications, not direct complications. Yes, but then itself, initially, is just the irregularity and then infertility aspect.
I see, and infertility is, I think, it's a big thing.
Yes, in our sub-region, it's a big thing.
Yeah, it's a very, very okay. I like the one you said in our sub-region, but because some people in the Western world, they may not.
Yeah, I think it's because based on the cultural value. So for us, it's a big thing.
So. Okay, is it treatable?
Yes, very treatable. Unfortunately, there's no cure. So usually once you are diagnosed, you have to receive some counseling.
Okay.
To teach you how to live with it, because it's technically lifetime. So that's usually a hard part for a lot of ladies, you know. But once you understand what you are up against, and with good support, family, clinical or medical support, you usually could achieve everything you want to achieve. I mean, for those wanting to conceive, you can conceive.
Okay.
You actually ovulate. The question is when.
Oh.
So it does not mean, usually does not mean you're infertile, you can never have children. That is not true. You can always conceive. So once you are diagnosed, they counsel you, you get to know what's ahead of you, you have regular clinical visits. And then whatever objective you want, if you want to achieve, usually our plan is to draw a plan with regards to the symptoms,
okay,
the severity, and then the patient's goals or wishes.
Okay.
If she wants to just regulate her cycle like everybody else,
okay, yeah,
we'll look at it as a short-term goal and achieve that. If she wants to later on switch to conception, we'll just switch things around and we'll do conception.
Okay.
Right. Yes.
So still talking about management of this condition, you've given us how the steps or what you would do when it comes to a lady trying to get pregnant, and also for the regulating the. Is there anything that can be done for the facial hair?
Oh yes, there are several treatments of facial hair. There are pills, there are creams that you can take. And also depends on usually it's directly linked to the male hormone level.
Okay.
So if the hormone levels are high, depending on where there's a starting point, they give medication to drop it. And once you drop it, then they can take care of the hair too, as well as a separate treatment. So you could also use laser treatments and everything to get it out. So there are several ways. So, but it depends on the lady herself. If she wants to go through the process. But some don't mind.
They stay like that?
Yes, some don't mind. So I've seen a few who don't mind.
I see.
Who actually enjoy it.
Seriously?
Yes. So it depends on the lady, but there are options available if you want to take it.
Okay, well, I see, I get their point. Maybe they are just trying to accept their uniqueness in a way.
Exactly. So some see that, so that's my own unique way.
Oh, that's true. Okay, we are already rounding up. I think we are done. What would be your advice, your last words to our viewers, emphasizing on the need to always visit your GYN, that routine check, which all of us, most of us are guilty of?
Well, I know. Well, in our environment, unfortunately, it's not a culture to be checking regularly. Most people show up when there's a problem.
Sure.
So, but I think that everybody should have at least once a year check. You know, for a lady under 35, you could check, let's say, breast exam. It's October, October, month of breast exam. We do a regular yearly pap smear, cervical cancer screen, at least just these two. You know, if you don't have reproductive hormone issues, menstrual cycle problems, no recurrent vaginal infections, then that's fine. These two alone should suffice. You know, beyond 35 on to 40, blood sugar, in addition to these as well.
Yes,
you know, blood pressure and all that, cholesterol, all those. So you should just once a year check shouldn't take. I'm sure you have some at least one day in a year that's free to go check yourself. So I think yes, it's a good habit to develop.
Sure.
And it will definitely pay off.
I think it would really help us to. We shouldn't wait till we are having an issue, and by then I think at times it's already gotten to the advanced stage that nothing much can be done about it, as against if you had gone early and they can just nip it in the bud and take care of it. How has it, just an aside, how has it been this during this COVID period, this pandemic, and your work? How have you been coping?
Well, every doctor is taking a frontliner.
Sure. Yeah.
Even though you're not enlisted, you are taking a frontliner.
Sure.
So, well, it makes, from the work perspective, I think that the risk is there. We all try to take precautions to make sure that you don't get yourself infected. You know, it somehow affected the attendance at the hospital. Everybody thinks COVID is in the hospital. Actually, it's in the community near you. But I think it's in her hospital, so it's affected attendance rates so much degree. Yes, but I think that on the whole, as a nation, we've sort of pulled through well. We are not 100% over it yet, but we pull through well. So I think
have the regular GYN visit, as our doctor has said. Many thanks to my production team who made this show a possibility till I come your way next week. I am Johnny Kuya. You are. Do stay tuned. Bye.
The Association of African Universities, AAU, is an international non-governmental organization set up by universities in Africa to promote cooperation among themselves and the international academic community.
Mon nom est professeur Étienne Ehouan-Ehilé. Je suis le secrétaire général de l'Association des universités africaines qui est basée à Accra, au Ghana. Je vais vous parler de la création de l'Association des universités africaines. Il faut remonter dans les années 60 pour pouvoir comprendre le processus. Déjà en 1960, nos dirigeants estimaient que l'éducation est l'outil majeur pour pouvoir lutter contre la pauvreté et assurer le développement.
I am Nodumo Dlamini. I'm the Director of ICT Services and Knowledge Management at the Association of African Universities. The Association of African Universities is a network of 400 universities in Africa. The biggest value that the universities benefit from being members of the association is this big platform that allows them to collaborate, allows them to work together, allows them to teach together. Through this platform, a university in North Africa can work with a university in Southern Africa, and also those in East Africa can work with those in West Africa.
Founded November 1967 at a conference in Rabat, Morocco, by heads of African higher education institutions, the association is currently headquartered in Accra, Ghana.
My name is Maxwell Amo-Hoyt. I'm the Director of Finance of the Association of African Universities. The association sustains itself from contributions from member universities and also from other development partners. Some of our development partners include the World Bank, other governmental agencies like the Swedish International Development Agency, UK Department for International Development, and other partners. We also receive a lot of support from other governments, especially the government of Ghana. Other partners include the African Union, which is more or less the parent organization of the Association of African Universities. The Association of African Universities hosts the Secretariat for the African Union's Continental Education Strategy. And by so doing, we provide coordinating roles for the African Union in helping members achieve their targets.
Déjà en 1960, nos dirigeants estimaient que l'éducation est l'outil majeur pour pouvoir lutter contre la pauvreté et assurer le développement. Et rappelons-nous que les années 60, la décade 60, a été une décade où la plupart des pays africains ont obtenu leur indépendance ou ont, disons, pris les dispositions pour être indépendants. C'était donc aussi l'année de développement, dans la mesure où tous ces pays indépendants devaient se retrouver de temps en temps pour parler de comment mettre ensemble leurs problèmes et trouver une solution commune.
And international agendas on higher education, including the continental